psoriasis is not contagious. It cannot be passed on from person to person through infectious methods. I'm Sarika Ramachandran. I'm a board-certified dermatologist, and today we're going to talk about the basics of psoriasis. Why is it that we get these scales in psoriasis? So what happens in the normal skin is that you get skin cells that slowly move up through the top layer of the skin and then shed. That process in normal skin will take approximately 28 days. In psoriasis, this process happens faster and we get what's called hyperproliferation. And so these skin cells are building up, they hang on, and that's where you see those thick plaques, those lesions of psoriasis. It is part of potentially an autoimmune process with the interplay of genetics and environment. And all of those things interplay to produce psoriatic lesion. So when we're talking about psoriasis, we think about scaly patches or plaques, areas of skin. But psoriasis can present in many different ways. Sometimes it can be pink-red, but in some skin tones it can also look purple, brown. The scales can vary. They can be white or gray. They tend to be thick scales. And then the interesting thing is psoriasis can look different when we've treated it. So treated psoriasis can actually start to flatten out. In some patients, it can leave some hyperpigmentation or darkening of the skin. So all of those can look different. And then different patients can also have different types of psoriasis, and the different types can appear different even in one individual. One of the most common types of psoriasis is plaque psoriasis. Plaque psoriasis presents as large plaques of skin change. It tends to have thick scales. It can affect different parts of the body, but the areas that we commonly see it on are the elbows, the knees. We can sometimes see it above the backside. Other forms of psoriasis include a guttate type of psoriasis with the small lesions that show up sometimes after infections such as strep. We also can have inverse psoriasis that tends to be in folds, and these can appear as moist plaques, sometimes bright red in those locations. We also can get pustular psoriasis, which presents as yellow bumps, little pus-filled bumps that can occur on different parts of the body, but sometimes are located on the hands and the feet, the palms and the plantar, or the bottom parts of the feet. And then we have erythrodermic psoriasis, and that's where a patient can have a lot of redness throughout their skin. So we can also think of it in terms of where is the psoriasis located. We have scalp psoriasis, and that can present as thick, scaly plaques, sometimes confused with dandruff that you can see in the same location. You can also get psoriasis on the nails. And you can get the inverse type of psoriasis that we were talking about before, usually in the folds, so along the groin area, under the armpits. So there are definitely forms of psoriasis that can be located to certain parts, but it's important to remember that each individual patient is different, and each patient can be affected in different areas, and a lot of areas in some cases as well. So when you put your finger over a lesion of psoriasis, it tends to be a little bit elevated. So psoriasis tends to feel thick in areas, particularly if they're untreated, but sometimes some psoriasis can feel not quite as thick. It can be like flatter, especially if it's been treated already. Sometimes psoriasis can be itchy, but itch is not always described in psoriasis. Patients can feel discomfort at the areas of the lesions. In addition to skin lesions of psoriasis, some patients can have psoriatic arthritis, and that can be painful. Some people with some of the pustular forms of psoriasis can experience pain. Some of the patients that experience erythrodermic psoriasis can also have pain associated with the redness that you have with that. Interestingly, some of the psoriasis lesions can bleed easily as well. They're rubbed or if they're traumatized in some way. In terms of psoriasis treatment, this is a really exciting time and a hopeful time because there have been many new treatments that have come out for psoriasis in the last decade, 2 decades. So these are kind of the 3 broad categories. So we have topical medications that are applied, we have systemic medications that can be taken by mouth or injected, and then we have phototherapy, which can be used for psoriasis. How we determine which medication is appropriate can depend on the severity of the lesions, how much body surface area, which parts of the body are affected, whether a patient has psoriatic arthritis. So there are a lot of different things that can affect it. When we're thinking about psoriasis limited to a small body surface area, using topical steroids is one of the first things that we start with. In addition to topical medications that are steroids, there are also non-steroids. Sometimes we have psoriasis that can be more extensive or not responsive to the topical medications. And that's sometimes where we add in some of the more systemic medications. So these systemic medications can be oral, they can be injection subcutaneously, or they can be received IV. Some of these medications can be immunosuppressive medications, which can offer broad immunosuppression that can help with psoriasis. And in the last few decades, we've been using medications called biologics, which tend to target a specific portion of the immune system. In dermatology, one of the neat types of treatments that we have is phototherapy. Phototherapy is where we use ultraviolet light essentially to help control certain diseases, including psoriasis, but it's actually been used for other diseases as well, which include eczema, vitiligo, and others. In some offices, we have a light box. We have narrowband ultraviolet light that can be administered to areas, large areas of the skin. Some patients actually can get a home light box. The treatment with the narrowband ultraviolet light tends to, at least initially, occur 2 to 3 times a week, and then you stay in the box for a certain amount of time. And when we're talking about the narrowband ultraviolet light, it's a specific wavelength of light that's administered. So this is very different from, say, just going out and getting exposure outside or going into like a tanning booth. So this is a really important distinction to make because you want to make sure that you are under the guidance of a physician if you're doing phototherapy and you're getting the right treatment. It's important to know that psoriasis can be something that may exist for long periods of time, lifelong, but there are lots of treatments that can be used to help make it feel better and to help really lessen the symptoms and the manifestations of the disease. Thanks so much for watching. For more videos like this, hit subscribe to be notified for more videos from Healthline.